Everyone. Good morning, good afternoon, good evening. And I know it's very early in the morning for Priti. So thank you so much. And a very, very warm welcome from Dawn to all of you. I'm Vanita Nayak Mukherjee. I'm based in Delhi, India. And I'm Dawn's executive committee member and a co-coordinator with Geeta Sen for the Feminists for a People's Vaccine campaign. It's great to meet all of you in our virtual space here. Please introduce yourselves with your name and organization in the chat and your country if possible. I'm just going to start with some brief housekeeping tips. Our Twitter handles are being shared in the chat box. I request all of you to tweet about this event. Our hashtag is FemForPeoplesVaccine. We will have 50 minutes of a facilitated conversation, followed by 25 minutes of question and answer. All questions and comments on the talk are very welcome, and we encourage all of you to ask anything that you want, even if you think, it's something that's very simple or not appropriate, given that these are extremely experienced lawyers speaking with us. So do write in the Q&A section as the conversation proceeds. It will make it easy for us to access and collate everything for our speakers. We are recording this session and it will be put up on the YouTube for a wider audience later on. To ensure that we get a good quality recording, all except speakers will be muted when the conversation is on. I'm seeing that more people have joining us. So welcome again for those who've just joined. A very quick word about Dawn Talks and the Feminists for a People's Vaccine campaign. Dawn Talks is a series of 4 conversations that began last year and is continuing this year with another 4. Last year, during the pandemic, we witnessed not just a health crisis, but an economic and a humanitarian crisis in some countries. As the crisis deepened and many things came up which were unexpected, unexperienced, unknown to us, we felt the need to make some sense of what was happening around us. We wanted to analyze the implications of the pandemic and all that it unleashed in our lives and reflect on the alternatives. Dawn, working from the Global South, is specifically focusing on feminist alternatives. So Dawn Talks last year was initiated as a way to make sense of this world and the deleterious effects of a pandemic and to reimagine a just and equitable world. So there are 2 streams of work that Dawn initiated during the pandemic. One is on the policy transformation with a focus on macroeconomic policies and on migration and social protection and the ways in which these are changing with deep impacts on women and gender using an intersectional lens. Our second stream of work during the pandemic is a campaign called the Feminists for a People's Vaccine campaign, FPV campaign for short. It focuses on the deep inequalities in access to medicines and vaccines and is working towards making COVID-19 vaccines, drugs, therapeutics accessible to all. So please do visit our website, the FPV website. The link is in the chat box. The website is packed with rich set of resources and it is a space for engagement with the campaign. The campaign is a very exciting partnership with several global, regional and national organizations with Dawn and Third World Network acting as a hub. So all 4 Dawn Talks from last year are available on the YouTube and on our Dawn website. See the chat box for our URL. This year, Dawn Talks began last month in August. It was on social protection and informal workers, and it was a part of our policy transformation piece. Today's talk is the second in the series, and we are focusing on the Feminists for a People's Vaccine. So there are 2 more talks in the pipeline in September and October. So I'll now stop and invite, sorry, I think I got muted. I'm sorry, I got muted. Yeah. I now invite Chi Oakling, who's the Executive Director of the Third World Network and is holding this talk, to say a few words and introduce our fabulous speakers, Priti, Sangeeta, and Leena. Over to you, Yokling.
Thank you very much, Vanita, and good day, good evening, good morning to everyone who's joined us. For Third World Network, and I'm speaking to you from Malaysia. For Third World Network, it's very exciting to partner with Dawn on the Feminists for People's Vaccine Initiative. And as Vanita said, this was really driven by the whole fundamental reimagination of the world that we need to actually move towards from the Dawn side. And for Third World Network, the structural inequities, the structural barriers to real human rights, and especially how women within the human rights framing have always continued to be much more structurally impacted. So for us, coming together in the Feminists for People's Vaccine Initiative is really a dream come true in many ways. Because I say that because the women's rights movement and the feminist community have always been at the forefront of taking some of the most fundamental challenges forward. And we feel that, we believe very strongly that when the feminist movement joined the access to medicines and the right to health movement, it will be a very powerful force. So we are really honored to be able to work with Dawn on this Dawn Talk series. And tonight we have 3 women who have in different parts of their lives intersected with each other and ended up working together. I've had the privilege of working with all of them in different ways and together as well. So we have tonight with us, and they're all lawyers. It's not by design, it's just that these women, law is a profession where, it's corporate power, you can become a judge, and for women from the South especially, to become a lawyer is something that really is an amazing thing for any family. So for lawyers to go into the world of public rights and activism and change is really something that is a double whammy. And for women, and most of the women who are actually in the legal activism movement are very powerful women. And it is really the women who are responding to that deep injustice. So it's not a surprise that we do have tonight and today, this morning, wherever you are, these 3 amazing women. So we have Leena Menghaney from based in Delhi. She is a feminist lawyer, and she has been working as a access to treatment activist for several years already, and she's with the Médecins sans Frontières access campaign. Then from Auckland, USA, across the ocean, we have Priti Krishtel, who is a health justice lawyer, and she's a co-founder of I-MAK that has within the United States really challenged in the heart of the capitalist system, from where intellectual property, monopoly, and profiteering using the legal instrument of intellectual property has basically come from and globalized. So the work done in the United States by people like Priti is very, very important. So we're very happy to have her here with us today. And then we have Sangeeta Shashikant, my colleague, whom I'm proud to work with. She's based in the UK, and she runs the Intellectual Property and Development Program of Third World Network. And the 3 of them will have a conversation this evening, and they will be sharing with us where they come from, where they're heading for in terms of reimagining the intellectual property system. So thank you again to all of you for being here, and to the 3 conversationalists, activist lawyers, most amazing women. Over to you, Priti.
Thank you so much. That was a great introduction. So I'll just start by saying that when I first heard about Feminists for People's Vaccine, I felt my heart leap up. And I think it's because after having done this work for so long, we haven't had this kind of space created for us, as women, as feminists, to really sit back and think about, we do this work on intellectual property and on access to medicines, but what is it about that that's connected to our lives? What is the feminist lens on this work? And so I've known Leena and Sangeeta for a very long time, but I'm appreciating even this opportunity to be able to ask them these questions. So with that, I'll just start off by asking each of you, how did you first come to this work? And what, from a feminist perspective, has kept you in this work over time? Maybe Leena, if you can kick us off.
Yeah. So it's, the feminist movement, interestingly, has been part of most rights movements. And I started my career with a feminist organization working on sexual rights. This was the time when people were dying of AIDS, and the sexual rights movement And the HIV/AIDS movements were deeply connected. And when I arrived in the Lawyers Collective, I watched my colleagues write wills, and we were doing these sessions on stigma and discrimination. And we were basically, people were trying to keep themselves alive. And at that point of time, when Treatment Action Campaign in South Africa started the battle for antiretrovirals, and I saw that pamphlet about ARVs, and it was just that moment which attracted me to the access movement, was that, yes, if we get the antiretrovirals, life-saving drugs, it could change the equation on stigma, on employment rights, and so many fronts for people living with HIV. And we had to get those drugs. And standing between those drugs and people living with HIV were the governments who, were rationing treatment or not providing treatment, and the pharmaceutical corporations who had the monopolies on them. And that's how, in the Lawyers Collective, when I started working on HIV/AIDS, I got involved in the access to treatment movement, and that was largely how I arrived looking at life-saving treatment as the pathway for other rights for people living with HIV/AIDS. Yeah.
Yeah, and I remember those days, Leena, because so many of the clients who your team saw or my team saw were women, were people who were putting their children into guardianship, or who didn't have equal rights in all of these other areas, right? Property, criminal law, like so many areas where they were disproportionately disadvantaged. So
absolutely. And one of the things that we saw was that when treatment was expensive, it was invariably the man in the family who got put on treatment, and his partner who was HIV positive got left behind. So we had to do something about making the treatment so affordable that governments would just give it out to everybody who was HIV positive. And I think that's where we arrived from the rights movement and the access to treatment movement, I would say. Yeah.
Sangeeta, what about you? How did you first come to the work, and what's kept you here for so long?
Thanks, Priti. So my experience is a bit different from Leena. My experience on access to medicines actually started with the work at the international level. So I have always been quite fascinated by, what are the factors that influence the formulation of national policies and, its impact on people's lives. And actually that was one of the reasons I joined Third World Network in 2004, because a Third World Network was really established to support the developing countries, because there was such a strong realization that whatever policies are made at the national level, especially trade, there are all these international rules that ultimately have a huge impact, and they impact the lives of people. And we wanted to change the power dynamics in the negotiation processes, such as the World Trade Organization. These are processes that are dominated and controlled by the US and other industrialized nations. So the idea was really to support coalition building amongst like-minded developing countries, providing technical support, analysis, to change the power dynamics in terms of how they entered into the negotiation processes. Now, in the area of intellectual property, historically, actually, the standards of intellectual property have been set in another organization called the World Intellectual Property Organization, WIPO. Many of you all may not have heard about it. But what WIPO lacked was enforcement capability. And so you see, Big Pharma did forum shifting. They lobbied the United States government as rules were being crafted internationally on trade. Big Pharma like Pfizer lobbied the US and pushed for minimum standards in the World Trade Organization, because the World Trade Organization had teeth. It had a dispute settlement mechanism. So if countries do not follow these rules, they can place some sanctions. So this strategic forum shifting is what we have, what we all now know as the TRIPS agreement in the WTO. So what we see is that while prior to these international trade rules, governments had more freedom. They did not have to put in place these laws, because this intellectual property system grants the pharmaceutical sector monopoly over medicines that save lives. So they put in place this system, which was then put in place a huge monopoly mechanism to control access to affordable treatment. So while previously developing countries had all this space. With the WTO TRIPS agreement, this space was eroded. And this totally changed the entry of the TRIPS agreement, which totally globalized the intellectual property rules, changed how developing countries could get access. So at the national level, all countries have to put in place these laws, except for a category of countries known as least developed countries. And we see that Big Pharma is not even satisfied with the WTO TRIPS agreement. They keep pushing for stronger and stronger standards via bilateral free trade agreements to strengthen their monopoly. So what has really motivated this work for me is really that, as Leena said, in the end, it is the access to treatment. If you have access to treatment, it changes everything. And we see that these rules at the international level, which then has impact at what a government can do at the national level, and its implementation. Patent offices granting these patents, they decide actually whether you have access to affordable treatment or not. So in the end, it is a matter of life and death. And if you see in the context of COVID, when it comes to inequity to access, as Leena has mentioned, it is the women from global south that actually disproportionately affected. We see in COVID, the health workforce, it's largely the women, right? They are the frontliners. They are at most risk at actually contracting COVID. When you have national lockdown, it's the women that actually have to bear the brunt of this crisis and the national lockdown. So I think when it comes to inequity to access, I think that it has a very strong connection in the sense that we are really dealing with rules that impact whether, many people, whether you live and die, whether a government has access, whether a government is able to actually realize its right to health at the very basic level.
That's really powerful. And so, Leena, you realized then, you said, we left off where you said that you realized that treatment could change everything. So what happened next for you once you realized that? What was your journey into intellectual property and access?
Yeah, it was amazing. I think we started to learn the names of these medicines. I remember lamivudine and stauridine. But I think there was a pivotal moment in the rights movement where a lot of activists from South Africa, Latin America, UK, MSF, all landed up in Bombay in that crucial moment, March 2005, and they were there when the law was being amended on intellectual property in India. Now, till then, if anybody knows about India, there have been a couple of big law firms, and particularly one, which is very well known in the field of intellectual property, that had dominated policy making in India on intellectual property. And we were a bunch of young activists who met in Bombay under the umbrella of the Lawyers Collective and Treatment Action Campaign and Act of Paris. And when the law was being changed in the Indian Parliament, we decided all to fly to New Delhi, some of us. And for 7 days, relentlessly, we lobbied and asked, for safeguards to be put into the law. And one of them was a pivotal safeguard, which would actually change the equation of power into the hands of the people who were most affected. Was a provision on pre-grant opposition, where people had the right to challenge a patent before it was granted. And I think it completely changed the way we looked at the law. We had meetings with people living with HIV. And I remember at that time, Priti, who's a colleague of mine, and Anand telling me that we have to challenge these patents. And MSF writing to us about this absolutely important drug called tenofovir. And I actually thought they were crazy. I thought we were going to challenge multinational corporations, intellectual property, and how are we going to draft all this, and how are we going to get to this? And Priti and Anand were so confident that we could do it. Then, it was just a matter of, organizing ourselves. We didn't have the funds. People living with HIV were brilliant activists, Lone Ganke, Abraham, KK Abraham, we all got together. And we logged an opposition, a patent challenge to Gilead's tenofovir. Till then, only 40 people across the world in the developing world in South Africa had access to the drug in the developing world, people of color, literally. The rest of it was in the West, in the developed countries, where it was routine treatment. And on 10th of May, when we logged in, it was peak summer in May, when we went to log in those oppositions at the patent office, and we marched to Jantar Mantar, which we no longer have the right to do so. We were sweating and we were screaming and we were rallying. And within days, Gilead actually flew to India to do something about licensing with Indian companies. And that's another story. But what it did was it shifted the power from governments and pharmaceutical corporations into the hands of the very people who were impacted by the intellectual property law. And I think that was such a pivotal moment for all of us in the rights movement. We didn't have the money, but we were absolutely determined to challenge those patterns. And today, tenofovir is one of the most widely used treatments in the world. It's the backbone of HIV/AIDS treatment anywhere in the world. It's the most, manufactured pill in the world. And the rights movement actually did that. They put those treatments into the hands of people. And I think that's where we should be looking at and changing intellectual property law.
You're taking me back. One of the memories I have of going to the patent office that first time with you and with Loon and everybody to file that case. I don't know if you remember this, but there were farmers there too, filing their patent opposition for the first time. And that was the first moment, I think, where it struck me just, how cross-cutting and intersectional IP actually is, because it affects so many communities across so many issues, even beyond treatment, in agriculture and all of these different issues as climate change grows. And so that memory has always stayed with me, because I don't know that we've ever seen the full potential of the movement grow. Like you're saying, that is the next step to put the power back in the hands of people. It's really beautifully said. And maybe that's a good transition over to you, Sangeeta, because you're talking about how TWN was thinking about shifting that power dynamic. So after you entered the field, maybe you can say more about what was happening in the movement at that time, and how was TWN itself thinking about shifting those power dynamics?
Yeah, so Priti, you raised this issue of IP being cross-cutting. So one of my area of work is actually fighting for farmers' rights and the rights to seed. And there again, it's a real tension with the intellectual property system, because it's really being imposed on, the practices that farmers were to do. So it's truly a cross-cutting issue. But in whether it's access to medicines, it's farmers' rights, and across all these public interest issues, and development issues, what we have is a cause of tension when it comes to the use of flexibility. So Leena spoke about the grant of the use of pre-grant opposition system, a very important flexibility that activists have and generic manufacturers and government have, to challenge the grant of patents. But the use of flexibility is such has created such tension between the developed countries and the developing countries, because on the one hand, we have this TRIPS agreement. Different countries have different interpretation based on their socioeconomic, their political interests. And so you have developing countries trying to use these flexibilities. On the other side, we have the pharmaceutical industries, with the support of the US government and the developed countries, undermining the use of flexibilities wherever they can. And Leena spoke about, the case in South Africa we had in 1998, 39 multinational companies taking South African government to court over the use of flexibilities. This is after the TRIPS agreement had come into force. And we had activists like South African Treatment Action Campaign, which launched a massive campaign which eventually led to the companies dropping their suit. But this was really the beginning of this, the tension between developing and developing countries in using that flexibility. South Africa was just one case. We also have a case of Brazil, where the US government took Brazil to the WTO dispute settlement mechanism in 2001. And again, this was really a warning to the developing countries not to use these flexibilities. The policy space that countries had, even despite the TRIPS agreement, to actually promote access. And so all this US bullying was really fiercely opposed. And what was happening at the international level at that time was really a push by the Africa group in the WTO. They called for a special session in 2001 because as countries were using this flexibility, South Africa, Brazil, Argentina was also, Argentina's use of trade secret, the flexibility with respect to getting regulatory approval for pharmaceutical products was also challenged by the US government. So all of this came to a head in 2001 in the WTO, with the Africa group putting in a proposal calling for interpretation and clarification of these flexibilities. There was a special session in June 2001 in the TRIPS Council, and the discussions were intense between the US and then the US industrialized countries. Actually, if you look at the history of it, they were repeatedly, we see some of these discussions actually being repeated in the WTO currently. They were totally opposed to any clarification that granted developing countries a greater policy space to implement these flexibilities and to use it for access to medicines. In fact, they used to argue, the US government used to argue, give us concrete examples where access has been hindered. And it reminds me, as I was preparing for this session, it reminds me the EU is asking the EU, the industrialized countries in the WTO currently, they also make similar suggestions saying that IP is not an issue, as it was in 2001. So we see a lot of similarities in the discussion that happened then and now. But just going back, all of this discussion led to the Doha Declaration on TRIPS and Public Health in 2001, which very importantly reaffirmed the right of governments to take the measures necessary to protect public health. Most importantly, it reaffirmed the right of governments to issue compulsory license. This is a license granted by a government without the consent of the patent holder to exploit the patented invention. Now, this is a very concrete flexibility that is provided by the TRIPS agreement. So after the Doha Declaration, and when I really joined TWN at that time, actually, TWN was more focused on actually building awareness and flexibility that was available in the TRIPS agreement, because all of this was clarified by the Doha Declaration. So to promote access, to promote the adoption of best practices for national implementation, and what lessons countries have learned from the use of flexibilities. And actually, we were in a very good place to actually advocate the use of these flexibilities, because we had firsthand experience in how these flexibilities can promote access. So Malaysia was the first Asian country to use and issue compulsory license for government use to override the patents of GSK and Bristol Myers on Lamivudine and Combovir. They issued it so that it can import more affordable ARVs from Cipla in India. And what we saw was that the average cost of treatment for the Ministry of Health dropped from US $300 per patient per month to less than $50 per patient per month. So this is almost 81% reduction in price when generic medicines were used. And even more interesting was the observation that the originator themselves reduced their price by 90%. So we had all these examples. And so we tried to connect the international discussions with national and regional discussions. And with Malaysia doing it, we also saw several Southeast Asian countries doing it, not just for ARVs, but also for cancer. For instance, Thailand issued for several cancer treatments as well. We also had Indonesia, Zimbabwe, Ghana. So I think this was really, the Doha Declaration did help with the clarification of the use of flexibility. But this does not mean that there was no pressure on developing countries. I think the pressure did continue. And we have seen activists play a real central role in challenging the IP system, in supporting countries in using these flexibilities, and in challenging pressures that come by in using these flexibilities eventually.
Both of you are painting a picture right now of work that works at multiple levels, right? These international instruments, the national laws, and then what was happening with community-led interventions. And one of the things I've always been struck by in the work is when we work with, Leena, for example, works with so many feminist networks, whether you're talking about organizations in India that are women-led, or in Argentina with, Lorena De Giano and Fundación HEP, explicitly feminist networks that are leading patent work in different countries, and then how that sort of leads up to these legal instruments that TWN and others are working on as well. So it's very interconnected. For me, one of the reasons that I always see this work as feminist and intersectional is because of how interconnected so many of these groups are around the world. You know, even when we look back to when you all started, we were all barely on email at that time. I think we didn't even have the internet, right? But the solidarity was still there, which is such a powerful thing. I wanted to ask next, maybe you can take this one, Leena, about after you both were working at all of these levels to shift the power to community or to countries, there was a pivot in the movement to expand, to go beyond working on HIV and cancer to also working on hepatitis C. And I wondered if you could tell us that story.
Yeah, so, you know, this was a moment in 2005 and, 2007 when the life-saving antiretrovirals for HIV were coming in, and finally people were getting life-saving treatments. But we realized something, and for all of us who worked within marginalized communities, that people were still dying of co-infections or infections such as hepatitis C. So, in MSF's Manipur project, for example, we had people living with HIV who were doing very well on the antiretrovirals, but the livers were affected by hepatitis C, and we didn't have a very affordable treatment at that time for hepatitis C. And I remember at that time was the first time we started to talk about biological medicines, pegylated interferon. It was it's a really toxic drug, doesn't work in the majority of cases. And sometimes patients describe the treatment as worse than the cure itself, the drug as worse than the treatment itself. And then I realized that even organizations like MSF, who had been buying all these generic medicines, couldn't break through into using of biological medicines. They had many, many questions. And as communities who were working on drug use, we knew that hepatitis C was, killing the community. A lot of people were dying. And we started to do what perhaps MSF and other organizations have started to do. We started to look at, are there any new drugs in the pipeline? And we discovered that Gilead had this oral medicine, sofosbuvir, and other companies like BMS also had them. And even before they were named by the WHO, I remember 7797, we wanted to go after these patents. We knew that Gilead would not easily give access to these drugs. And in the United States, they launched them at $1,000 a pill. So all of us, the poorest and the most marginalized, the drug users, probably been to jail several times, the organizations that run the harm reduction groups, all of us in Asia got together and started this movement that even before the treatment was actually registered, we would challenge those patents. And this is how far we went within the rights movement. And these movements were led by the most marginalized people. And actually, MSF tremendously benefited from that, I have to say, in our medical projects when the treatment started to flow. And in challenging those patents, we realized that we were doing it drug by drug, and disease by disease. And there came this realization that as activists, we need to change the system. We can't fight this drug by drug, disease by disease. And even though we were incredibly resourceful, we ran a buyers club. So, patients from other countries would, hook up to activists in India, and we would get the generic medicines to China, to Australia, to Eastern Europe, to Canada. We would hand carry treatments for people with hepatitis C. But we knew that in breaking the law, we were actually respecting rights. But we needed to change the system. That realization has started to come within us, that this cannot go on, this drug by battle for access, in a way, I would say, yeah.
Sangeeta, do you have anything to add on the hepatitis C story?
Yeah, so hepatitis C, Malaysia has a very good example, in terms of how we scaled up access. It's an example that other countries need to follow. Leena was very much involved in that story. So in Malaysia, we have an estimate of 500,000 patients. Annually, it seems 2,000 newly diagnosed patients get hepatitis C. 1 in 10 are female. And as Leena mentioned, they were using pegylated interferon. I think they were paying about $3,000. But the side effects, if you speak to the patients, were horrendous. And here we had antiviral. You take it, you're cured, right? But the cost was crazy. It was like one patient in Malaysia paid $91,000. This is just for sofosbuvir. Sofosbuvir is patented in Malaysia, so we could not get access to generic. Malaysia was considered to be an upper middle income country, so we were not included in the voluntary licenses that Gilead was entering into with generic suppliers, like for instance in India. Malaysia could not be supplied under these voluntary licenses. These are just bilateral agreements allowing between Gilead and Indian manufacturers, allowing the Indian manufacturers to produce and to export. But Malaysia was excluded from that list of countries that could, benefit from that VL, because it was considered to be upper middle income country. Now, sofosbuvir has to be used. Sofosbuvir is the backbone therapy. It has to be used with another antiviral. So for the genotypes that are present in Malaysia, it has to be used with daclatasvir. That was considered to be the optimal treatment. Daclatasvir was not patented in Malaysia, but we were also excluded from the voluntary license that BMS entered into. For some reason, we were excluded because they didn't want to set a precedent, where upper middle income countries are included in the agreement. So we needed these two antivirals, huge problem. And for sofosbuvir, one patient paid $91,000, and it was a comparable price for daclatasvir. Unsustainable. If you want a government, we are talking of hepatitis C, which is an infectious disease. It's just unsustainable for a government. So we invited Leena over to Malaysia in 2015. We organized a meeting, bringing in the government officials, civil society experts like Leena, local manufacturers, to just discuss what options we have, what is the situation with respect to access to hepatitis C treatment, what options that we have. So we narrowed down. One option was to negotiate price. Another option was to use some of the flexibilities. And clearly, one clear example was to use compulsory license and to import the affordable generic. Now that was in 2015. It took for 2 years. We engaged the government, the civil society, different agencies, providing support, technical input, just examples of how CLS have been used. The Ministry of Health on its part tried to negotiate with the patent holder, thinking that they would get lower prices, and they did get lower prices, but it's not low enough for it to be sustainable for public health. Even if you reduce from $90,000 to $10,000, $6,000, it's not sustainable. We have got budgets that are very limited in developing countries. So how do you roll out treatment if your treatment costs $6,000, $9,000? So it was not feasible. So in the end, they took the decision in 2017. The government issued the cabinet took the decision to issue a compulsory license for use by the government. This compulsory license would import generic sofosbuvir from an Egyptian manufacturer. Now, interestingly, as soon as Gilead heard that news, Gilead issued a tweet. It was just a tweet saying that they would now allow VL, Malaysia, to be supplied under VL, and not just Malaysia, but also Thailand, because activists in Thailand were also similarly fighting for access, Ukraine, Belarus. So they included 4 countries, including Malaysia, into this supply for VL. Now, what was the aim? The aim was to just stop the issuance of CL. The aim was to get the Malaysian government to abandon the use of a compulsory license. But the Malaysian government continued with the compulsory license, because the government had as its core, its objective that we have to bring down the cost of treatment. And the CL did that. It brought the cost of treatment, combined treatment for sofosbuvir and daclatasvir down to less than $300. And with that, they were able to roll out free treatment to about 20 over public hospitals. And since then, they have had put in proper testing for hepatitis C. You see, because it became a chicken and egg situation. If you do not have proper treatment, you do not want to engage into more testing. And if you do not engage in more testing, you do not know how many patients are out there with hepatitis C. So, to get out of the situation, the government issued a CL. Once you bring down the price, the government can definitely roll out testing and to roll out treatment freely. But this was not the end of the pressure, because between 2017, when the government announced its issuance of CL, to 2019, constant pressure by Gilead, by the various government agencies. We were informed that there were at least 17 meetings with different agencies in Malaysia, from the Prime Minister, Minister of Health, the officials in the ministries of health, all to get the government to abandon the license. They offered donations, but they did not work. They threatened sanctions. So this is how they have tried to create confusion wherever they can. But I think here, the civil society can play a very strong role in just providing the necessary information, to support the efforts of the government. And in our case, the Malaysian government did stand firm, and we did benefit greatly from the use of flexibility, that really brought the price down. And I think that is really an example how rules at the national level, if you have the right rules and policies in place, it can really go a long way to promote access.
Yeah, and so I think this is an amazing example of a success story in the movement. For hepatitis C, also Leena's organization, Sangeeta's and mine, spent many years in different countries trying to challenge the hepatitis C patents. And I see that Ramya and Priti are in the panelist list too. So there's amazing women lawyers all over the world, actually, and men and others who have tried to join this fight to challenge hepatitis C patents all over the world. And it's, this has been one of the tougher journeys for the movement. Like Leena said, trying to remember exactly what you said, Leena, it's sort of the turning point where we realize that drug by drug, case by case is not actually serving us. It's where we have to now go to the system and start to exert pressure to get the system itself to change. So before we get into that, which is I think where we land in this journey with COVID and everything that's happening right now with the intellectual property debate, I just want to do one more story and ask Leena, can you share the story of the breast cancer drug Herceptin and how the movement responded to that drug?
Yeah, so interestingly, women in developed countries had fought and challenged the Swiss pharmaceutical corporation, Roche, to give them access to this life-saving breast cancer drug, trastuzumab. In many women with HER2 breast cancer, it prevents the cancer from being metastasized. And they had, pushed Roche to give access during the clinical trials. The story of trastuzumab was very different in the developing world. Today the treatment of cancer and breast cancer is what? Cut, slash, and burn. That's what we do to our breasts, and to our tissues. And after doing that, we have no guarantee that the cancer will not come back into our bodies. And trastuzumab in some ways offered this opportunity to women to after the cancer treatment, to undergo this treatment that would prevent the cancer from coming back into their bodies. And someone from the feminist movement, Kalyani Menon-Sen, contacted, the Third World Network and the MSF office in New Delhi, asking, the doctor said that, there's this drug, but I can't offer it, to her colleague, because, it just wouldn't be fair to tell her this drug existed, but it was too expensive. And Kalyani wanted to know why it was expensive. And I think this is a question that we need to keep asking, why are drugs so expensive? And she came to MSF and TWN. At that time, MSF did not work on trastuzumab or biological medicines. And Gopa from Third World Network and me and Kalyani wrote to the Prime Minister saying, we are very concerned about access to this drug. And to our great surprise, the Ministry of Health reacted and set up a committee on compulsory licensing, which is what Sangeeta just spoke about, saying, well, why not issue a license to a competitor of Roche to make the drug more affordable in the Indian market, to have competition in the market? And we started to work with the government to make submissions on compulsory licensing. We wrote letters to the patent office highlighting how patents had been wrongly granted. And I think it was in 2014 or 15 when Roche withdrew its patent monopoly in India. And in a matter of days, Biocon, another company in India, launched a more affordable product. And it was, all the experience that we had as activists working on access to medicines for ARVs and hepatitis C that we utilize to at least get the drug in India for women. It's still not very affordable, but nevertheless, it's not $2,000 a vial either. And what was very, very interesting was it triggered a response from women from across the world, from South Africa, from Argentina. And the same stories came out about pharmaceutical corporations. Roche wouldn't lower the price. In one case in South Africa, negotiations to lower the price and get access to the drug continued till the woman died. She died, and still they would not lower the price. So for them, lives were expendable, and particularly, women of color. And we managed to get access to the drug, and the battle for trastuzumab continues in many parts of the world by organizations who work on cancer and women's rights activists. Yeah, and it's been a great honor to be being able to work with the feminist movement on and going back to my roots to be able to do something about access to this breast cancer drug.
So maybe now we've heard, across disease areas, across strategies, how the movement has responded to lack of access. But now we're in a different moment, right? Because COVID, when it hit us, a little over a year and a half ago, it shifted from being a movement that responded to diseases that affected some people to being something that literally touches everyone's lives, every home, every country. And so, Sangeeta, I'm curious for your observations. What shifted with COVID? And when the pandemic first hit, how did you all respond? And through that, I would love to hear what are your thoughts on the TRIPS waiver as well at the WTO, and maybe you can actually give some background and explain that for our listeners.
Yeah, so what we see is really a repeat of inequity, HIV, Hep C. These are just some examples we have raised today, but you look at cancer treatment, huge inequity. If you look at HIV/AIDS, it took 10 years or so for affordable access, scaling up of treatment in the global South. But it's worse in this pandemic because we are dealing with a mutating virus. We have, to the extent you have got vulnerable populations, you're going to get more and more perhaps dangerous variants evading vaccines and existing treatment. And so, it's really mind-boggling. We all know equitable access is fundamental to controlling this pandemic. We heard beginning of the pandemic, all these global promises, international solidarity, global public goods, but we have not seen any delivery on these promises. What we have seen is hoarding of vaccines. And we see it until today. We are almost 1.5 years, almost close to 2 years into the pandemic. Situation has not changed. It has worsened in terms of its access. We see Africa, last I checked, it was still 4% in terms of its level of vaccination. But meanwhile, we see booster doses, booster doses already being administered in the rich countries. Teenagers, children being vaccinated in a lot of rich countries as well. So inequity, staggering inequity between developed and developing countries. And needless to say, women are very much bearing the brunt of this crisis. As I mentioned earlier, they're disproportionately impacted the longer the pandemic affects everyone globally. If you look at the poorest nations, 32 million people are going to be entering into poverty. That was estimated in 2020. We do not know the estimate for 2021. And in the years coming, we're all behind SDGs even before the pandemic. Social and economic development is being rolled back. Education is being impacted. At the heart and core of this are actually women being affected. Now, the question is, has production and supply changed? Has the business model of Big Pharma changed? No. Business model for Big Pharma is business as usual. Okay, maybe we enter into a few more manufacturing agreements here and there to show that we are making some effort, but it's business as usual. What we see is licensing agreements, manufacturing agreements, mainly contract manufacturing agreements, where the multinational companies are basically controlling production and supply and the prices. And, I think we spent 6 months, 8 months discussing whether there is manufacturing capacity in global South. Although we know that most of the vaccine supply in the last few years, and even WHO's data shows that WHO's pre-queued vaccine are a lot of it in developing countries, in India, in Brazil, in Argentina. So, we have spent so much time discussing whether there is vaccine manufacturing capacity, where we all know that there is existing manufacturing capacity. So, I mean, if we really want equitable access, so when we look at ARV, we were talking about more affordability. In this pandemic, it's not just affordability, it's availability and affordability, because there's a shortage in terms of vaccines, not just vaccines, but also therapeutics. Even diagnostics, we're in the same position as well. Testing in low and middle income countries is disastrous. And to the extent you do not have sufficient testing happening, you do not know what kind of variants are circulating. So we are actually prolonging the pandemic by not doing what is really needed. And what we really need is to scale up global manufacturing. We need to diversify suppliers globally, especially in developing countries. And to do this, we need to address intellectual property issues. We cannot say we close a blind eye to intellectual property. Across what is needed for the containment of COVID, whether it's masks, test kits, vaccines, therapeutics, if you want to do manufacturing of these products and any of its components, we need to address intellectual property. And here we are not just talking about patents. We're also talking about trade secret protection. We're also talking about industrial design, copyright. These are all categories of intellectual property where we have not really paid enough attention to how it actually hinders access, it hinders supply, especially the discussion around trade secret, because we have always typically talked about patents and its impact, and we don't touch enough about protection of trade secret and what it means for access. So there are all these different categories of intellectual property. They all hinder production, supply, and access. And I think this is the context and the relevance of the TRIPS waiver proposal that has been proposed by India and South Africa, and now it's supported by 64 developing countries. And I see huge support. The huge support is because there is a recognition that we need to lift this intellectual property monopolies. We need to share that technology, that know-how, and that knowledge, not because there's no capacity in developing countries, but more that because of the way the entire system is structured, we need to expedite manufacturing. If not, we can wait 10 years, for manufacturers in developing countries and to overcome the barriers. But there is capacity, and if you were to actually lift this intellectual monopoly, we would go a long way in expediting, in expanding supply and in expediting access. And actually controlling the pandemic. We have lost so much time in having a lot of these discussions just because the developed countries and big pharma want to control what is out there so that it can control prices. This is all in the end about money and profits. If you look at mRNA technology, Pfizer has already made 33 billion this year. And if it maintains its monopoly, it can make 33 billion for the next few years. So it's all about making profits. But unfortunately, it comes at a huge cost to society, to lives, livelihoods, and increasing poverty, unemployment, at the end of it, impacting women. Now, just to mention that actually, when we talk of waiver is a legal instrument provided by the WTO. And it has been used on several occasions. It's normally used in exceptional circumstances. And the main idea behind a waiver is really to have that freedom to operate by lifting the intellectual property monopolies. So we do not have to, so that we avoid the procedural and administrative delays. Do we really need to do compulsory license each product, follow the conditions of issuing a compulsory license? It's not feasible because of the scale of supply that we need. So I think there is a whole moral imperative to, if we want to control the pandemic, we really need to take action. And the waiver is really to put government in the seat. Right now, production and supply is being run by big pharma. We really need governments to actually be in the seat and actually take the necessary measures. And this is what the waiver allows them to do. We should also need to clarify some of the flexibilities, because on the one hand, while there is the developed countries say, your flexibilities, use them. They have for the last decade or so, as we discussed, systematically undermines its use. They have discouraged developing countries from using flexibility. Now they're turning around and saying, please use the flexibility. So there is a huge, dishonesty in some of the arguments the developed countries have been putting forward. They are the ones that have actually told developing countries don't use. They keep putting pressures, sanctions, and now they're saying, oh, but you have this flexibility, so we don't need any other tools. So we are, and we're also seeing the worst of big pharma here through its various bullying methods, strategies. We see Pfizer going as far as requiring governments to provide sovereign assets as guarantee, so that they can have indemnified in the case of liability. So I think there's much work to be done. And I think the TRIPS waiver discussion brings forth a lot of these inequity rules. It also shows how the international system trade rules claims to be working, but it's not working. Yeah, in the end, it's impacting lives of people. Yeah. I think the unfortunate thing is that the rich countries also do not see that actually, if we were to control this pandemic, it's good for them, because here we are in danger of different variants circulating and evading these vaccines and its efficacy.
So Sangeeta, you've mentioned a few times across different disease areas, and obviously COVID, that women are the most impacted. And I would add to that, women are the most impacted, but we haven't necessarily seen yet feminist-led, feminist-centered version of this access to medicines movement, where it is a feminist or intersectional agenda that's driving what happens. Many of us, of course, women across different countries have worked together. We have led different strategies, but I think I'm picturing something even more in this direction as we go forward. So maybe let me just ask you the question. If feminists were to lead this fight now for access to medicines and to reimagine the intellectual property system going forward, what does that future look like for both of you? And either one of you is welcome to start.
Yeah, I think we really have to firstly address the intellectual property rules that we have at the international level. I think it is time that we reviewed what it really, its value. There's all these narratives going around, about how it contributes to R&D, how important it is as an incentive. But if you look at the hard facts, if you look at COVID, a lot of the R&D has been driven by public funding, but there are no conditionalities. They are not committed to. They do not have to commit to providing any kind of access. They do not have to commit to providing transparency on their R&D cost. So I think we really need to mobilize movements, women's movements, to actually raise some of these issues at the national level and also at the international level, because at the end of the day, these rules are provided at the international level. So I think this is a very important aspect. We have seen all of these issues come forward in the context of COVID, but there is no obligation on big pharma on the big pharma to actually commit in any way whatsoever on access. When we talk of COVID and variants in the context of COVID, right? They depend, if you look at the development of COVID vaccines, they have depended on collaboration, international collaboration. The sharing of sequence information. Moderna has used the sequence information from China to produce its mRNA vaccine, the collaboration in clinical trials. So it has been a global effort supply, but they do not have any commitments to provide supply and access. All of that is so-called voluntary, and we can see huge inequities arising as a result. So we are only talking of COVID here, but we see similar situations emerging for other diseases as well. So I think we really need to question a lot of the basic narrative put forward by Big Pharma, and to unpack it and to really consider whether the intellectual property system is really working in favor of R&D and access at the end of the day.
Leena, what about you?
I write enough technical documents with MSF. So, some of what I'm going to articulate is more open to open up the conversation and not necessarily MSF's opinion. What I feel is this, that while we are making the technical arguments about who actually invests in R&D and, all the technical arguments that go into the cost of production, what I would do is, put on another frame of lens of rights and gender and caste and see the system from that point of view. This is a system that is being built to serve a few privileged countries and people, and leave the rest of us to watch while the outcomes of research are privately owned. So you collective science, collective research, but privately owned outcomes. And I think within this, I would just like to, sort of highlight this issue. I mean, there are issues about, this is the remnants of the colonization. If you look at South Africa and India, we inherited our patent systems from the UK, from the British. We're still in South Africa trying to undo that damage. If you look at the debate on COVID-19 today, it reminds you of the debates during colonization, when a few handful of countries who were the colonizers would argue that they're intellectually superior and therefore entitled to rule over the colonies. And today, the same arguments that, in some ways that they are technologically superior and they have the right to manufacture, and in somehow, developing countries do not have the technical know-how and are somehow intellectually inferior to be able to organize themselves into producing life-saving treatments and vaccines. And I think we have to now start deconstructing those arguments being made in our faces. You just can no longer accept the conversation about lack of manufacturing capacity, poor quality, production, deliberately, mixing up those arguments to mislead people that are all often introduced into the discussion by pharma corporations or wealthy countries. And I think this is where I would very much like people to put on those lenses. And I know many people in the rights movement will have far more tools to do that than perhaps some of us who are IP geeks or trade geeks, And number two, I would say is this, that if I were to reimagine the intellectual property system, I would really look at three things. One is the right to know, to the transparency around the intellectual property system, what patents are granted, why they're granted, who grants them, all of those things that go into empowering people. Number two, I would shift the power to grant compulsory licenses, the power to apply and get compulsory licenses into the hands of people like we did for pre-grant oppositions. Today, governments decide that compulsory license will be granted or not. And that's what is disempowering people from benefiting from a system that was supposed to benefit them. And compulsory licenses should very much be in the hands of people and their ability to mobilize a compulsory license for their own benefit. That is not happening as of now. Governments decide. So people get caught between governments and pharma corporations. And if you ask me, an extreme step I would take, and nothing to do with my professional opinion, I would break up the big corporations. I would break up Novartis, Roche, Pfizer, not because of any other reason, but because they have so much political power to influence governments and to vitiate the whole process of policy making. And I think this is where, corporations have to be brought accountable for the millions of lives that are being lost across the world. These corporations then decide what is going to happen to our lives. And I think I would definitely look at dismantling the power of big corporations. And I think no longer are $1,000 pills or $2,000 a cancer drug that goes at $2,000 a dose, or a COVID vaccine that bankrupts the government is acceptable. So I would go much further because of COVID, because I don't think so we have the time to keep doing this, as I said, by drug product anymore. Yeah.
Those are really powerful responses, and to me reflect the depth of both of your experience in the field too. I'm mindful of time, so I want to transition us. We have a lot of questions that came in. Okay, so we have actually a very interesting spectrum of questions. So maybe I will just mention a couple of them. Let me start with two that are on the opposite end of the spectrum. One came in that asked, why would anybody invest huge sums in R&D if there is no patent monopoly protection? Especially as you're saying, they're against human rights and promote inequality. Without innovation and R&D, generic drug manufacturers like Cipla wouldn't have been able to mass produce AIDS drugs, for example. So that's on the one side. And then another question came in, which asked, why don't we legally question the basis for even granting intellectual property to products? Because access is a matter of life and death. You know, the COVID vaccine in particular, as Sangeeta also mentioned, the funding has been so heavily given by the public. So why don't we even question like the root of IPR? So I don't know which one of you wants to take which of these two questions. Or do you want me to pick?
Whichever.
Okay. Yeah, maybe Leena, if you take the, why would anybody invest in R&D if there was no protection? What's the incentive for firms? And then Sangeeta, maybe you can say, why aren't we legally questioning the very basis of granting intellectual property in the first place?
Well, you know, the first question comes at us at every meeting, you know, and I think one of the things that we also, you know, constantly sort of highlight is the fact that, you know, the public has been constantly investing in R&D, even the Indian public. If you look at today, the might of Indian generic companies is built on subsidized land, tax waivers, you know, and that's true in different ways. Governments have subsidized, you know, R&D. My question is, does the outcome of that system of intellectual property have to be so extreme, where it has to result only in a monopoly? Can we not reform the system to, you know, change to what other industries have done, which is, you know, a much more, licensable system, where you would be automatically a competitor would be able to, you know, utilize the technology and pay a certain sum or royalty for the same? Why does it have to be in an extreme format of a monopoly, leaving, you know, a pharmaceutical company in charge of deciding prices the world over? So that's my first response. And number two is this, that irrespective of whether we think of, you know, I would say, put it this way, that, you know, whether the R&D system and IP system are actually linked, you know, humans have been very innovative throughout their human history, and you know, the intellectual property system is relatively new. So it's not as if, you know, human ingenuity is only connected to intellectual property. But nevertheless, if we were to sort of look at the intellectual property system, it cannot function the way it's functioning at the moment, which is, for example, if you look at South Asia, not a single person has got an mRNA vaccine. And so the extreme outcome of monopoly control or control over technology and intellectual property. And I think the questions and the solutions have to be, you know, put up by governments, actually, to be very frankly. And it's not up to us as activists to say these are our solutions. We are pointing out a massive problem in the system where patients can't get access, people are facing discrimination, governments are rationing treatment. So let's come up with a solution, and governments have to come up with a solution, and not the band-aid solution, which is one drug, one compulsory license, a complete rehaul of the system. And that's what I would start, you know, discussing, whether we want to go deeper into the reform system on a rights-based perspective of intellectual property. Intellectual property system can be rights-based if we were to choose to, you know, start discussing reform without having pharma companies on the table.
Yeah, so I mean, I think my question is linked to very much what Leena has said. I mean, we have in reality this TRIPS agreement, so we have to deal with it. There is a built-in clause for reviewing that entire IP system, but we have never really had that kind of a discussion. There have been some discussions in the WTO, about the use of certain mechanisms and whether, for those who know, there's a mechanism for supplying countries with insufficient manufacturing capacity. But it's riddled with so many procedural barriers that, it's barely been used and even where that has been questioned, the narrative is that there's just no problem, And I think at the root of it, the main question, the main argument is that the IP system is the most important system because it provides an incentive, but it's really not working. And I think it's quite clear from the COVID situation. It's not just not working in developing countries. We have similar problems in developed countries, in rich countries as well. Similar problems of access as well, isn't it? So I think we do need to challenge the system, but we do need, I mean, the way the mechanism, the international rules are made is that it's made in WTO, it's binding. So we do need governments to challenge this entire intellectual property rules, and whether, as Leena said, is it necessary for us to have such extreme outcomes, where companies make billions of dollars at profits and comes at the expense of lives? Do we really need such a system? Can we have a system of maybe statutory licenses, automatic licenses? I think we really need to have this discussion. We are only talking about some patents that are granted. Actually, the way the entire system is being abused by the patent holders, where they grant a lot of, they apply for a lot of the, patents over incremental changes that they make to existing compounds. So we see that sometimes drugs that should have been out of patent continue in patent for more than 20 years, 30 years, 40 years, because of the whole abuse of the patent system. And now there is actually existing information, literature that shows that actually while new chemical entities are, declining, we see actually patents, the number of patents being granted increasing. So there are fundamental flaws in the system, and we really need to raise these issues as civil society. And I think get governments to raise it at the international level, because there's a clear fundamental systemic problem that we have when we talk about access.
So we have about 5 minutes, and I have a lot of questions here. So let me see if I can merge a couple.
Priti, if I can just come in.
Oh, yeah,
if our audience is open to staying on for another 5-10 minutes, we can continue. So I think we should, yeah.
Yeah, so I'm gonna raise 2 of the questions at once again that are coming up, which I think are critiques of the generics industry in India specifically. One participant is raising that, licensing models already exist and generics are not investing in R&D related to new drugs. They're waiting for patents to expire. Another participant is raising that the pharmaceutical industry in India is no longer committed to really providing free, or even I would add low-cost medication for Indians or for export markets that may not be as lucrative, because they're now seeing the export potential to certain countries as being more lucrative. So what needs to be, that participant is asking what essential mechanisms have to be put in place in addition to the fight for things like the TRIPS waiver to address that issue. So again, two sides of the same coin.
Yeah, Leena might want to take it. It's about India.
Yeah. So I think there's several layers to the 2, questions. And I would say this, that firstly, as activists, we very well know that any pharma industry is capable and needs regulation. I mean, it's not just about big pharma. This is about the whole industry as such. Number 2 is this, that I was just speaking to a friend of mine, and we were discussing Sputnik, and Indian companies have incredibly started to improve the process of production on Sputnik, and this is where I think the strengths of different countries lie, because India built its entire technology around process technology and improving the yield of raw materials. So India is incredibly, and its manufacturers are incredibly smart at improving and lowering the cost of production. The US has invested in a model that is incredibly good at producing newer drugs for at least not the neglected diseases or infectious diseases, but at least for the chronic diseases. And so in that sense, I think countries need to be more collaborative about their strengths, and not have this nationalistic agenda about the fact that India can't do new drugs, and the US is investing all the money in R&D. And I think we need to have a less nationalistic structure to our discussion. There are strengths in China, there are strengths in South Korea, there are strengths in India, there are strengths in the US. And of course, there's strengths in the Oxford University in the UK. How can we collaborate to make sure that the system works better for people? And I don't think so you can use the spectrum of nationalism any longer when it comes to life-saving treatments. Yes, of course, India could do far better on R&D in terms of supporting more R&D, but India is already starting to take a few steps. Like, for example, the TrueNat has come from an Indian manufacturer, which is a direct competitor to CIFID. You are seeing CRISPR technology-based tests coming out. And what I can say is that there is incredible innovative capacity in countries like Brazil, India, Egypt, Bangladesh, South Korea, waiting to be harnessed for global public health. And in that sense, I would be less nationalistic in my way of looking at only India being the pharmacy of the developing world. I would like to see Bangladesh, Egypt, South Korea, many other countries play that role in different areas and therapeutic diseases. And I just feel that, invariably it turns into a conversation about the generic industry versus big pharma. This is not a conversation about generic industry versus big pharma. This is a conversation about people getting the treatment that they deserve. So I would very much use that framework for that. And more recently, India has stopped producing the policy papers that used to define pharma policy in India. And you can see that the impact has been how the industry is looking outwards instead of the domestic market or how to benefit Indian patients. And I think it can be changed with policy making, and that can be addressed through policy making.
So one final question here, maybe for you, Sangeeta, is, are there countries using the flexibilities you've been talking about in relation to COVID vaccines?
Yeah, I think we have seen several countries using flexibilities, although more in the area of therapeutics, especially to manufacture and to maybe for domestic use, maybe even to export. I think what comes to mind is more therapeutics. I'm not sure about the area of vaccines, but definitely in the area of therapeutics, we have seen, especially with respect to remdesivir, we have got Russia that issued a compulsory license for local manufacturing, but also I think it was mainly for local manufacturing. I think they did try to export to India when India was going through a raging COVID COVID-19 third wave, but they were not able to, I think, because of certain conditions attached. Normally you would see it has to be predominantly for the supply of the domestic market. We had Hungary issue a compulsory license. We do not know in the end whether they actually did in fact use it, because they have certain data exclusivity provisions that which could create a barrier to using that compulsory license. We had Israel use it for lopinavir, ritonavir. At that time, beginning of the pandemic, it was considered to be especially useful treatment. So there are certain cases. We have had Bangladesh. Bangladesh is a least developed country. As a least developed country, it does not have to put in place pharmaceutical product patent protection for pharmaceutical product. And so Bangladesh has got no patent protection. And so it's able to easily manufacture for itself and also for export. Now, in the area of vaccines, the issue is a bit complex because, especially if you look at mRNA, the mRNA technology, there are many patents across, the production, the vaccine itself, its different parts, the underlying technology. There are multiple patent holders as well, because it doesn't mean that Pfizer owns all the patents around its vaccine. The underlying technology has been licensed from other patent holders. So the situation with respect to vaccines is more complex. There was a case of where BioLease in Canada said that it could produce a version of the J&J vaccine. Now, for BioLease could produce for purpose of export, not for use in Canada. So it had to use this mechanism, international mechanism under the WTO rules, known as the Article 31 bis mechanism, which is about manufacturing for purpose of export to countries with insufficient manufacturing capacity. And BioLease notified its government that it wanted a CL. Bolivia said that it wanted to import from Canada, and they also did the notification. But the Canadian government has refused to issue a compulsory license. And so that this mechanism, which requires importing and exporting countries to follow numerous procedural requirements, is often made worse by national laws, has been quite ineffective. The reason this mechanism came into play was because when you use compulsory license under the TRIPS agreement, it has to be predominantly for the supply of the domestic market. Now, that means you cannot manufacture for purpose of export, and to waive that and to create a mechanism for exporting with countries which did not have the capacity to manufacture, they created this mechanism. But it has been barely used. The one time it was used was to export ARVs from Canada to Rwanda. It was a very painful, difficult, long process. And even the generic manufacturer in Canada that was involved said it was an impossible mechanism to use. So in this COVID, there has been one of the arguments is that this entire mechanism does not work. It's complicated. And the fact that we need expeditious supply, we cannot be expecting countries to follow this kind of notification requirements, issuing compulsory license, and because you need it in both countries, in importing and exporting country, if there are patents in each of these countries. So there have been that one measure in the area of vaccines has really been BioLease and Bolivia. They've tried to use the mechanism, but they have not been successful to date. Although BioLease made that notification, I think it was in March, that it could actually manufacture the J&J vaccine, and Canadian government has not issued a compulsory license for that purpose. So there is that challenge we face when we start talking about vaccines. In therapeutics, there have been some situations where it has been used.
So I just want to wrap up by doing a quick recap of what you both said about what a feminist future for this work could look like, because I thought it was extremely profound and worth capturing again. Sangeeta, you imagined a future where we would revisit and rewrite the rules, including just the underpinning of the narrative that IP is critical for R&D to even exist. And you talked about mobilizing movements to raise all of these issues, the structural issues at the national and international level. And Leena, you offered us 4 suggestions, really deconstructing some of the colonial foundations of the entire IP system that are leading to these quality arguments today. You talked about increasing transparency on which IP is granted and to who. And then maybe in a really forward-looking vision, you talked about shifting the power around compulsory licensing from governments even back to people. and breaking up the power of some of the largest pharmaceutical companies in the world. So I leave very inspired by both of those visions. I hope that they are closer than we think. And maybe Vanita, now we'll hand it back to you for some closing remarks.
I think you have done a great job of summarizing. The most important piece of this conversation is looking forward and reimagining a feminist future where the community is in charge, where we change the IP rules. I mean, all those things that look so complicated seems to be so possible after listening to you all. Thank you so much, Priti, Sangeeta, Leena, for the most scintillating and inspiring talk. I'm sure all of us have learned a lot. I also want to thank TWN, the Third World Network, for collaborating on this Dawn Talks and for being our fabulous partners on the Feminists for a People's Vaccine campaign. And before I close, I'd just like everyone to know that this is a series of 4 Dawn Talks. 2 more are coming up in August and in September. And lastly, I want to thank our communications team who have made this possible. Tasmi Gomez, Ricardo, Jandira, and Marla. Thank you, everyone, and thanks to our audience for being so engaged, asking all those questions. I think this has been a very, very interesting conversation, and all of us have learned so much, and we look forward to working with you all. Thank you again.
Thank you. Thank you, Priti.
Yokling, would you like to say something before we close? Please come in.
I'm fine, thank you. Everything is just so, this was a great conversation. Thank you so much. And thank you to everyone. There's so much work to do. And I think we're all very excited about how we can actually work together. Thank you.
Yeah,
Thank you.
And thank
Bye.
you, Priti, for getting up so early.
Absolutely.
My pleasure.
Yeah, your solidarity. And we
Yeah,
really
exactly.
appreciate your solidarity. And thanks again.
Hi,
Yeah.
everyone. Thank you so much.
Bye.
Bye. So can we hang on?